In this particular section, we are going to discuss on autoimmune polyglandular syndromes, otherwise referred to as autoimmune polyendocrine syndromes. So what is the basic difference between a MEN syndrome or a MEON and APS? Well, in MEN syndrome, you have seen a lot of hypers and tumors, whereas in APS, you're going to see a lot of hypos because of autoimmune destruction of the glands. You have basically many different diseases that come under this APS category, but the most important being the three types, that is APS type 1, APS type 2, and IPEX. You would have noted a lot of data about this IPEX in the hematology section itself, that is immune polyendocrine X-linked, where it is due to FOXP3 gene mutations. Like I have given some basics there itself. In the T cell basics, if you go and search, it will be definitely there, where there is a problem in the T regulatory cell synthesis. And the disease that is associated with this T regulatory cell synthesis is what we called as IPEX. Okay, without wasting much time, let us move on to the APS types. The three most important types of APS, one is APS type 1, and second one is APS type 2, and the third one is IPEX, immune polyendocrine X-linked. APS type 1 per se is rare, whereas IPEX is very, very rare, whereas APS type 2 tends to be relatively common. Genetics wise, APS1 is due to problems of the IR gene, that is called autoimmune regulator. We have discussed about this IR gene extensively in the hematology section itself, in the T cell basics, where it is important for the selection of the T cells in the thymus. Autoimmune regulator, where it actually expresses the antigens from different parts of the body. It is present in chromosome number 21, and this disease is inherited as autosomal recessive. Whereas IPEX, it is due to FOXP3 mutations, which means they are going to have reduced number of T regulatory cells, and because of that, they develop the autoimmunity. Regulatory cells are the ones that fight against autoimmunity. So here don't have the regulatory cells, that's why. And this disease is going to be X-linked. That's why it's called IPEX. Whereas you don't have a definitive inheritance, or in the sense this APS type 2 tends to be polygenic inheritance, which means it's having a genetic basis as well as the environmental background. Now, when the disease will present, most of the APS type 1 cases is going to present in infancy. IPEX is going to present in the neonatal period itself. Even though APS type 2 presentation is variable, APS type 2 generally tends to present in adulthood. Is there any HLA association? HLA association is very, very poor. You do have, but still very poor association. No association with IPEX. APS type 2, on the other hand, has an enormous and tremendous HLA association in the form of they can be associated with HLA DR3, they can be associated with HLA DR4, they can be associated with HLA DQ8 and DQ2, and a lot of HLAs. DR3, and DR4, these are associated with multiple autoimmune disorders like rheumatoid arthritis, DR4, DQ2, DQ8, celiac disease. These are associated with multiple other diseases as well, autoimmune diseases. And where will you have immunodeficiency? Immunodeficiency is a feature of APS type 1. It's usually not a feature of APS type 2 and IPEX, but it's generally a very important feature of APS type 1. What is the reason for immunodeficiency? Many of these patients will have asplenia, and that actually predisposes these patients to development of candidiasis. Very important point. Candidiasis risk is very high in these patients. We don't have this immunodeficiency in these people, APS type 2 and IPEX. What is the triad of features of APS type 1? They tend to have this recurrent and severe mucocutaneous candidiasis. At the same time, they tend to have Addison disease, that is adrenal insufficiency. They also tend to have this hypoparathyroidism. That's primary, usually primary hypoparathyroidism. Very, very important point. It's not hyper, it's hypo. Very commonly confused thing in exam. I told you only men's will produce hyper. APS is going to produce hypos. At the same time, if they ask you, is there any other features that you can think about when you think about APS type 1? Yes, I'm going to think about candidiasis, that is due to asplenia. At the same time, I can also think about ectodermal problems. They tend to have ectodermal dystrophy. Ectodermal dystrophy. So what are the evidence of ectodermal dystrophy? These patients tend to have nail dystrophy. They tend to have enamel hypoplasia. Enamel hypoplasia. They tend to have keratitis and retinitis. They also tend to have keratitis and retinitis. That is also one reason why this syndrome is also referred to as Apesed syndrome. Why it's called Apesed? Because A stands for autoimmune, P poly, E endocrine, C stands for candidiasis, EED stands for ectodermal dystrophy. Autoimmune polyendocrinopathy with candidiasis and ectodermal dystrophy. Clear? Very, very important. And what about this APS type 2? Again, you can remember this as a triad. They are going to have type 1A diabetes, which means they are type 1 diabetes that are associated with antibodies, autoantibodies. Clear? They don't have insulin at all. And they can have Addison, and they can have chronic thyroiditis resulting in hypothyroidism. That is due to chronic thyroiditis. Remember, even though I told you type 1A diabetes as a major feature of your APS type 2, type 1A diabetes can happen even in APS type 1, which means there are some common entities between these two. Those are type 1A diabetes, Addison disease, pernicious anemia, and vitiligo. Even though I told you the characteristic triads between these two, and I told you the type 1A usually goes towards APS type 2, that's correct, but this can happen in both. That's why I told you HLA association is poor, but can happen only with diabetes. Only with the diabetes component, HLA association is still there. What is HLA that's associated? That is HLA-DQ6. It's there, but only for the diabetes component, not for anything else. But the overall HLA association is very, very poor. What are the other features that is associated with APS type 2? That is the other autoimmune problems like myasthenia gravis, immune thrombocytopenic purpura, celiac disease, dermatitis herpetiformis, like other autoimmune conditions are associated with APS type 2. But remember, type 1 diabetes, pernicious anemia, vitiligo, Addison, all these are common between them. IPEX, again, you can remember by a triad. You can remember these patients tend to have neonatal diabetes mellitus. At the same time, they tend to have this IBD-like picture, especially ulcerative colitis-like picture, which can eventually result in malabsorption. And these patients, these IPEX patients, also tend to have hematological complications like hemolytic anemias and probably thrombocytopenia as well. So you should know this association, hematological association. Other features, generally, they don't have that much to be told. And finally, you have to know what are the reasons for death in these patients. Remember, type 1 APS, they generally die of adrenal crisis, or they can die of hypocalcemic crisis because of severe hypoparathyroidism, and they can die of cancers. That's a very, very important point again, this oral and esophageal cancers. Oral and esophageal cancers. If they ask you which of the following IPS has oral esophageal cancer risk, or which of the following APS has increased cancer risk, your answer must be APS type 1. Usual reason for death in APS type 2 is again adrenal crisis. Yes, and they die of diabetic complications. Yes, because the risk of getting type 1A diabetes is actually more with APS type 2. We discussed already. Whereas the usual reason for death in these patients is infections in IPEX patients. Remember, presence of antibodies to various cytokines is a very, very strong feature of APS type 1, which means they have antibodies against type 1 interferons, like interferon alpha, interferon omega, lot of interferons are there. Type 1 interferons, they can have antibodies against interleukin 17 and they can have antibodies against interleukin 22 also. These are cytokines of the T helper 17 pathway, we know that. They can have antibodies to cytokines. But this is not seen in other types of APS and IPEX, APS type 2 and IPEX. So this is again a very crucial question, antibodies to cytokines. But the organ-specific antibodies can be present in all these three entities. Organ-specific antibodies can be present in all these three disorders. It's not going to differentiate. So that's all. Let's summarize. What are the questions you will be asked in APS? Definitely the IR gene, sure short question, polygenic inheritance, FOXP3. Basic three things, you have to nail them. And asplenia candidiasis, type 1. Apacid, type 1. Hypoparathyroidism, type 1. Ectodermal problems, type 1. Increase of cancers, type 1. Antibody cytokines, type 1. Apart from that, these triads you should never forget. And IBD, IPEX, you have to know. And association with multiple other autoimmune problems is type 2 again, and it's polygenic inheritance, type 2. So these are some of the important points that you have to know. Then let us go for other polyendocrine and autoimmune disorders. What are the other polyendocrine autoimmune syndromes that are associated? Number one is the chromosomal abnormalities that you have to know, which can be associated with autoimmune endocrine syndromes, like Down syndrome and Turner syndrome. These syndromes can be associated with chronic thyroiditis, and because of that, they can go for hypothyroidism, and they can have type 1A diabetes as well. That is antibody-related diabetes mellitus. Second, you can get with Poem syndrome. You know Poem syndrome, we have discussed in detail about this Poem syndrome in the plasma cell dyscrasia chapter in the hematology. You are going to tell what is POEMS. It is an acronym that stands for polyneuropathy, organomegaly, endocrinopathy, and you're going to have M protein in the serum, that is serum M protein, and skin changes. So this is what we refer to as Poem syndrome. They tend to produce something called an osteosclerotic myeloma rather than an osteolytic myeloma. They produce a sclerotic myeloma. Note that point. We have discussed already in detail anyways. Number 3, you have something called a Hirata disease. Hirata disease will result in recurrent hypoglycemia. Recurrent hypoglycemia. What is the reason for this Hirata disease? You will develop insulin antibodies, insulin autoantibodies, antibodies against insulin. Which means you might ask the question, they should actually be prone for hyperglycemia, not hypoglycemia. How it works? It's very simple. Whenever you take a meal, you're going to increase the glucose levels in the blood, and to counteract this, you have to increase the insulin levels. But what is the problem here is this insulin will get bound to the insulin antibodies. These are the antibodies against the insulin. And now this insulin actually will not work on the insulin receptor because it's already bound to the antibodies. Now the glucose will not reduce, and this will make the pancreas to release more and more insulin. So they're going to produce more and more insulin, which is once again going to bind to more and more antibodies. So which means there is more than normal amount of insulin is released from the pancreas because the insulin is not working and the glucose is not controlled. And whatever it's released, it's getting bound to the antibodies. And after some time, these antibodies will dissociate. there will be dissociation of antibodies, and now you can see there's too much of free insulin. Lots and lots of free insulin is there, and this is going to produce severe hypoglycemia. So they can produce a fasting, or they can even produce a postprandial hypoglycemia also, depending on how much the antibodies are related to the insulin, or association of these antibodies with insulin, how long it will take. But definitely they will have fasting hypoglycemia. Whether postprandial hypoglycemia will be there or not depends. Will be there in some patients. This is what we refer to as Hirata disease. It may not be seen only in patients with unknown cause. It can be seen in any patient with conditions that are known to produce autoantibodies. Okay. Number 4, you have type B insulin resistance. Very rare disorder. So what do you mean by type B insulin resistance? Again, here the problem is the autoantibodies that are directed against insulin receptors. Insulin receptors. It can be seen in certain, as a secondary event in certain other autoimmune disorders like SLE also. So you cannot know. But these are autoantibodies against insulin receptors. Remember, you have insulin receptor, which is nothing but receptor tyrosine kinase. And the antibodies will bind. These are insulin receptor antibodies. And they're going to prevent the endogenous insulin from binding. So since the insulin cannot bind with this receptor, these patients, by feedback, they'll produce extremely high insulin. At the same time, they will develop signs of insulin resistance. Signs of insulin resistance. And they're going to go for extreme hyperglycemia. And paradoxically, they are prone for hypoglycemia also, which means both hyper as well as hypo can happen. So what is the difference between Hirata? Hirata will produce only hypo. Clear? At the same time, they will be having no signs of insulin resistance, and they'll have extremely high insulin levels. But whereas this type B insulin resistance patients are more prone for hyper than hypo, but they can develop severe hypo also sometimes. And there will be severe insulin resistance in these patients, like acanthosis, skin tags. A lot of signs of insulin resistance can be seen. And these patients also will have severe hyperinsulinemia. So hyperinsulinemic hypoglycemia, go for Hirata. One of the causes. Hyperinsulinemic hyperglycemia, think about your type B insulin resistance. Extreme levels of insulin resistance will be there in these patients. And signs of insulin resistance is not seen in Hirata, whereas it will be seen in your type B insulin resistance. Okay. Number 5, thymoma. Thymoma can be associated with red cell aplasia. We know that already. Myasthenia gravis, and even it can be associated with Graves' disease. That's why I'm telling here, because this is an endocrine problem. You can get with a syndrome called Wolfram syndrome. We are going to discuss in detail, otherwise referred to as Did-Mode syndrome. What do you mean by Wolfram syndrome or Did-Mode syndrome? You have diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. That's an acronym. Diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. Let us discuss more about Wolfram syndrome in the posterior pituitary section. And finally, you can also have endocrine problems with something called a Kearns-Sayre syndrome. Kearns-Sayre syndrome is a mitochondrial problem. It's a type of mitochondrial myopathy. We know that. So what are the features? Obviously, they are going to have CPO. Any mitochondrial problem, the hallmark is having this CPO. That's called a chronic progressive external ophthalmopathy, CPO. And these patients may have retinal degeneration as well, and they can have thyroiditis, they can have diabetes mellitus, and they can have hypoparathyroidism. Clear? Again, it's a hypoparathyroidism. So these are the endocrine component of this Kearns-Sayre syndrome. That's why I'm telling you here. Thyroiditis, diabetes mellitus, and they can have hypoparathyroidism. So again, these are endocrine components. That's why this is really important. So these are the other problems that can be associated with autoimmune endocrine problems. So I think we have discussed enough about and in details about this short topic, that is an autoimmune polyendocrine syndromes and syndromes associated with autoimmune endocrine disorders. So with this, we can close this section down and we can move on to the next major section on the posterior pituitary.